welcome to this panel of the symposium and the panel entitled Life Breath, where we have lovely presentations to look forward to. Unfortunately, Malusi let us know that he can't participate due to technical difficulties. So I think we should go straight to Steve Reid's presentation then. And sorry if I'm a bit clumsy, not so used to Zoom. We're doing Microsoft Teams all the time. But Steve, let me just do give you a short introduction, not that it's needed, I think. But Steve is a physician with a background in rural medicine. He's worked and run a district hospital in KwaZulu-Natal for 10 years with his wife, Dr. Janet Gee, who's also in the audience. He's an advocate for rural health in South Africa and is involved in medical education and human resources for health. He's also a musician, so therefore he's interested in the medical humanities and the role that the arts can play in medicine. He took up the post of the Glaxo Wellcome Chair of Primary Healthcare at UCT in 2010 and is developing this role to support medical and health sciences graduates to become more relevant and appropriately skilled in Africa. His inaugural lecture in 2011 was titled The Music of Health for All, and is involved in developing the role of the arts and social sciences in healthcare through the medical humanities within the African context. And today, Steve will talk to us about breathing and singing through COVID-19, through some very interesting experiences that he had, and we're all very much looking forward to hearing about that. Thank you so much, Steve. Over to you.
Thanks, Berna, and hello to everybody on this call. It's really nice to be part of this conference, and thanks to the organizers for getting it together. It's quite an amazing accomplishment to actually do one of these things. So we're all learning, we're all fumbling around the mute button and all of that. And I'm going to do what I can to share my screen and some videos. So I'm going to go straight to the presentation because I want to tell you about the experience we had in Cape Town at what's called the Hospital of Hope. Some of you will have been to the Cape Town International Convention Center, and that was turned into this hospital. And for 2 months, I was part of the medical team. And there were 862 beds, each with piped oxygen. And it was quite an engineering feat to get it all up and running in a very short space of time in May. But I want to give you some idea of the scale of things. There were these large 60-bedded wards in long rows in this cavernous exhibition hall. And there were about a total of about 450 staff members. We were about 30 South African doctors, and there were another 18 Cuban doctors who joined us. And we treated a total of 1,500 patients over 10 weeks. We got up to a maximum of about 430 patients that admitted at one time. We filled about 10 of those wards. And over the 10 weeks, there were 81 deaths. So those are some of the numbers. But it's the context in which we suited up in PPE, attempted to assist patients to breathe and to maintain adequate oxygen saturation levels. And I'm going to explain that in more detail. And to survive to discharge it, just like that sort of short-term vision that we started, and it was all hands on deck. So this is what it looked like. These, up to the partition there that you see halfway down this long row is 30 beds. And then beyond the partition is another 30 beds. So this is a ward of 60 beds, and there were 14 of these wards. So you can see the roof here. It's difficult to give you an idea of the scale of it, but it was rather overwhelming when we first went in and thought of all those beds being full, which we were fully expecting at that stage with in our PPE. But let me, I want to explain a little bit about intermediate care. So in field hospitals, intermediate care lies between acute care and chronic care. So between urgent emergency care and long-term care. And different hospitals are designed for these needs normally. And intermediate care is normally focused on rehabilitation, like with people with strokes or wounds that take a long time to heal, and most people would stay an average of about 6 weeks. It's also used for palliative care with terminally ill patients. So that's normally what intermediate care is, but this idea of a field hospital is taken from the military context, in which temporary hospitals, if they are moved around on the near the battlefront, can significantly improve survival rates of people who are wounded. So talk about metaphor as well. Anyway, this is what it looked like when we were kind of filling up. And this is actually the medical team at a consultant's ward round, with the photo taken by the consultant from Reid. And you can see all the beds up, all these 30 beds are full with patients, and the further 30 beds in the distance. And this was the full medical team on that day. All the doctors who were working that day, some of them consultants and some of them junior staff. So it gives you some idea of how busy it was, although it's difficult to convey that. And the important thing was here, you can hardly see them, but at every bed was an oxygen supply. There you see an oxygen tubing for each patient, and that was the currency. The admission criteria was that the patient needed to be dependent on oxygen. They couldn't go home without it. So breathing and oxygen were the central focus of this work. And what I need to explain is what we call the SATs, the oxygen saturation. Some of you will be familiar with this, but the saturation, the amount of oxygen in your blood, is easily measured with a finger probe, and it, as you probably know, it looks something like that. It's normally above 95%. If you're very ill, it drops to below 85%, and some people say that it's incompatible with life if it's less than 80%. Well, we admitted people with SATs of 65 and 70%, and they were talking to us. So something funny was going on with COVID. But we watched these numbers, primarily kept an eye on each of these. So each patient was linked up to one of these machines. Well, no, we had two or three in each ward, and we moved them around. And this was next to the patient's bed, and we'd watch the screen here, and particularly this number here, the oxygen saturate SpO2, which in this patient, in this reading, you see it's 98%. The ones above are just the pulse rate at the top and then the blood pressure. But we watched the SATs like a hawk. Like if you came up to a patient's bed, that's what you wanted to know. How are they doing today? How much oxygen are they using? And what are their SATs? And that determined whether they were getting better, whether they're getting worse, what we needed to do. Because we could supply oxygen at different levels. We could give it by face mask, we could dial it up to 10 liters per minute, we could give it by nasal prongs, which then allowed the person to talk and to eat and carry on, which is a bit more comfortable. And if they're really desperado, then we would transfer them to certain beds where they had high flow nasal oxygen. We could deliver 15 liters per minute with special nasal prongs. So this was really the focus of what we did every day for those few hundred patients. But there were other strategies, other medical strategies to improve outcomes, apart from oxygen. We routinely gave an anti-clotting drug called Clexane. From mid-June, we got new research findings from the UK and introduced steroids, and that made quite a difference to the recovery time. We often treated patients lying on their stomachs, so-called proning, which aerated different parts of the lung. And we paid a lot of attention to diabetic control and diet. And then the physios also made quite a difference. I don't know where that part went, but the physiotherapists got the patients breathing deeply, doing exercises in bed, and walking up and down slowly as they got better. So there was quite a lot that we could do medically, but beyond a certain point, it was really difficult to predict who was going to get worse and who was going to get better. And the majority of people just needed 3 or 4 days of oxygen, and then their requirements reduced, and they went home. The average length of stay, I think, was about 4.5 or 5 days. So the vast majority of patients got better and went home, including a 104-year-old, by the way, who danced out of there. So it was on the whole a very sort of gratifying to be part of that journey. But I want to share with you 2 stories that have relevance to medical humanities, and I hope that we'll have time to discuss them. The one was a particular patient who was 71 years old. He wasn't Mr. LA. He was not overweight, and he had no diabetes or hypertension or anything. And he was one of those admitted from Gritskeer for oxygen therapy because he'd apparently got over the acute stage and was just needing a couple more days of oxygen. So by day 5 of his admission, we noticed that rather than getting better, he needed higher levels of oxygen to maintain his SATs. So we escalated his oxygen. And by day 7, he got to the stage of needing high flow nasal oxygen. That's the 15 liters per minute by special nasal prongs. And that turns out to be, it's the step before intubating, putting a tube down the throat and sending them to ICU, which had very poor outcomes at that stage. So it was our last resort, really, at the field hospital. And on day 8, despite high flow nasal oxygen, his SATs were still below 90%. So he was not doing well. This is not a happy situation. And as I say, he wasn't overweight. He didn't seem to have any other big risk factors. So who this disease chose and who it left alone was entirely mysterious. We never knew. But the particular story I want to tell you is that we were in part of the care that we gave was to try and link patients up to their family members, usually by video call. We had Wi-Fi in the conference center, and we could video call the family to one of their cell phones, and the patient could have a link up with their family, because their family members are obviously not allowed to visit them in hospital. So we did this for Mr. LA, and the remarkable thing is that while talking to his family by video call, his saturation percentage actually rose to 93%. And we watched it from 86 to 93%. Now that's a remarkable rise. That you know, is way beyond anything that we could do medically. That degree of change over a few minutes. And I was absolutely fascinated by this. Like, how do you explain this phenomenon? What physiological explanation is there that gives such an instantaneous response to a holistic intervention, like speaking to his wife and family at home? And I've been really fascinated by that. So I'll come back to that story because there were other examples as well. Often we had to hold the cell phone for the patient because they're too ill to hold it themselves. So you're often in this conversation with the family that you didn't really want to be part of. It was quite tricky sometimes, and some of the doctors who did that were quite traumatized actually, because they knew that a particular patient wasn't going to make it, and that the conversation that they were having might have been their last with their wife or husband of 40 years or 50 years or whatever. So it was quite an extraordinary experience and series of experiences. But the other story I want to tell you, and this is the last one, is about one Sunday afternoon. So I said to the after about a few weeks, in fact, I think we were getting into July. You know, I'm tired of this sort of almost like industrial kind of environment. Surely we could do some singing here. So I went to the matron and said, do any of your nurses sing? Oh yes, she said. She knew some of them and she put the word out. So I said, could we do some singing in the wards? And she said, yes, no, I'm very much in favor of that, but it mustn't interrupt the medical work. So you can come on Sunday afternoon and you can sing with the nurses. I said, fine, okay, Sunday afternoon it is. And I pitched up there, and I spoke to the sister in charge and said, matron tells me that there's some of the nurses who like singing and would join me, you know, in singing around the wards. And I had in mind that maybe 3 or 4 would join me, and we would just slowly go through like a snake, up the one ward and down the other, and up the next and down the other. At that stage, I think almost all the wards were full. We were at our maximum. And so we started at the one end, and a lot of those nurses happened to be Zulu speaking, to my surprise. And so, of course, the default is Zulu gospel songs, which everybody knows, and it kind of gets everybody together. So we started down the ward 1, and it sort of grew beyond my expectations. By the time we got to the end of ward 2, we had about 20 staff members with us singing together. And by the time we got to about ward 4 or so, everybody had joined in. So I want to give you some idea of what that looked like. Is this full screen? By the time, this is about ward 4. So that's what it looked like and felt like. And by the time we got to about ward 6, it looked like this. I wanted to give you some idea that the patients, those who could walk, also joined in all the way around the wards, all 10 wards that were full on that at that time. And it was the most extraordinarily joyous afternoon. It was just amazing. It was like the lid came off of this suppressed sense of anxiety and worry about the medical side of things, and people had been desperate to sing and to move and to dance and to just let go. And so we did it again. I went most Sunday afternoons, and we sang through the wards, and by the end it became routine. This is what we do on Sundays. You know, we go through the ward singing Zulu gospel songs, and it was it really transformed the space from this factory-like medical environment to one in which we could really be human together. So let me finish by going to the end here. I think what I want to say is, whoa, how's that gone? There we go. Yeah, that the feedback from patients has been incredibly complimentary. We've had lots of spontaneous feedback, and we're just doing an analysis of a exit survey we did with the staff, which were extraordinarily positive. Many said it was really beyond their expectations and transformatory in various ways. They didn't expect this process. We were all rather fearful of it. We didn't know what to expect, really. And it was an incredibly positive and affirming process to be involved with this whole field hospital thing. But specifically the singing together, I think, allowed a humanity to be expressed despite the barriers of PPE, which were significant. If you think of a mask and a visor and even a Cuban accent, it's difficult to feel that you are making a connection with a patient or even a colleague. And of course, patients being isolated from their families and this industrial sort of environment. And the singing really bridged that. And in a life and death situation like a field hospital, it was the experience of teamwork towards a common purpose. That was very much a part of it. And these expressions of vulnerability that really made a difference. I don't know where those words went. Anyway, that's really what I wanted to say in conclusion, and we can make all sorts of analyses maybe or reflections on it by in the discussion. But the last little video I want to show you is there was a sweet Cuban doctor by the name of Jose, who seemed to be emboldened by the singing on Sundays and brought his guitar in to play to a patient of his, and it was really touching. It was really, he brought it specifically for her. He's playing with his gloves on, and everyone else is going about their business. So let me stop there, and I'd love to be able to understand in terms of medical humanities, you know, what was happening there. Yeah, thanks.
Oh, thank you, Steve. That was amazing. Thanks so much for sharing. I think we're all sitting with big smiles on our faces. I think the format we've agreed on is that we'll go to the next presentation. And then at the end, we'll have a time for discussion. Right, Charlotte? That's how we'll do it. Okay, but if you guys want to pop any comments or questions along in the chat box, you're also very welcome to do that. Thank you. Right, and then I see our next speaker, Neusa Torres. Neusa, am I pronouncing your name correctly?
Yes, Berna. It should be Neusa because the E in English is E in Portuguese, but I'm fine with Neusa.
No, let's do it right. Neusa, you see.
Neusa.
Neusa. Okay, hi, Neusa.
Like the E in Zulu, it's E, like yeah.
Okay.
Yes.
Okay, my Zulu is as bad as my Portuguese, so you'll have to help. Okay, lovely. Sorry, guys, let me just make my screen a bit smaller so I can see the program again. So our next speaker, sorry, let me just, I was so, staring at the screen of these singing doctors and nurses, I lost my place a little bit. Okay, so Neusa will give us a talk on the need to breathe properly, the practice of self-medication with antibiotics for viral respiratory tract infections. And let me just give you a short introduction to Neusa. She is a Mozambican national, an anthropologist, and also has a master's in public health with a PhD from the University of KwaZulu-Natal here in South Africa and from Durban. She works in Mozambique at the Higher Institute for Health Sciences with research interests in the medical humanities and public health. Currently working on medicine use and abuse and the practices of self-medication with antibiotics. And these are some of the things that she will talk to us about now. Right, so Neusa, if you're ready, you can start. I think Charlotte will do the timing for us. We usually allow about 20 minutes, and I think Charlotte will talk to you in the chat about the time if you start getting close to that. Okay, but I also, you missed that part. Our first presenter could unfortunately not join us. So, we have a little bit more time here. Okay, thank you. Over to you.
Okay, thank you very much, Berna. I hope everyone is listening to me. I don't know, because my network is a bit confusing today. It's a bit windy in Mozambique today and the networks are bad. So I hope you can see my slides, my presentation, and you can hear me properly. Please confirm, Ben.
Sorry, yes, I can hear you quite well. Yeah, okay. Great, and I can see your slides. Yes, Carla writes in the chat we can. Yes.
Okay, I'm sharing my slides.
Yes, we see them.
Okay.
Great.
Hello, everyone. As Berna said, my name is Neusa Torres. I'm from Mozambique. My presentation or my contribution to this symposium is regarding the practice of self-medication with antibiotics for viral respiratory tract infections. And be here to participate in this event. This work is part of my PhD studies, my PhD research, and I used extracts of the data I gathered during this process. So this is a preliminary exploration of the link between the practices of self-medication with antibiotics, SMA, for viral respiratory tract infection, discuss the rationales and the practice of self-medication for viral respiratory tract infections among pharmacy customers in Maputo City. These customers were recruited immediately after buying non-prescribed antibiotics from private pharmacies in Maputo City. And I conducted a qualitative work with in-depth interviews and focus group discussions with 32 pharmacy clients. Can say that antibiotics are those medicines used to prevent or treat infectious disease caused by bacteria. Okay, and their importance in health, in human health, make a plausible case for why antibiotics are one of the most utilized drugs in the world. So while the global health organizations such as WHO, CDC, claims for better use of antibiotics at all levels due to the public health problem of antibiotic resistance and antimicrobial resistance, this practice of self-medication with antibiotics, as well as the non-prescribed antibiotic dispensing, undermines the global efforts to rationalize the use of antibiotics and contain antibiotic resistance. Although self-medication is considered a component of self-care, the practice of SMA or self-medication with antibiotics is one of the most common forms of antibiotic misuse. So common cold, sore throat, and flu-like symptoms are syndromes most often found in humans. And these are important causes of viral respiratory tract infections according to Trinor and Aiden. So FTIs are expected for the majority of the population, with the symptoms usually resolving within 7 to 10 days without antibiotic treatment. However, these symptoms prompt patients to make therapeutic decisions and indulge in utilization of antibiotics without consulting a physician. In this study, I found that participants used 5 patterns or 5 ways to request or to have access to antibiotics without prescriptions. Before, let me say that pharmacists in this study admitted dispensing non-prescribed antibiotics, while the pharmacy clients admitted frequent practice of self-medication with antibiotics. So the 5 patterns or the 5 ways in which participants acquired antibiotics, non-prescribed antibiotics, were first referring to the more scientific, referring to the scientific, generic, or brand names of antibiotics. Second, referring to the physical appearance the symptoms and the health condition to the pharmacist, which means that then the pharmacist was advising in which antibiotic the patient could take or the client could buy and could take, administrate for the sake of their health. The fourth one was using old prescriptions. This means that the patients went to see a physician or a health professional before and reused the prescription for new sickness events. And last one was sharing health information and antibiotics with family members, friends, or neighbors, which means that some of the participants had leftover antibiotics and shared with other relatives or friends. These are the 5 patterns in which the participants acquired non-prescribed antibiotics. So antibiotics such as amoxicillin, cotrimoxazole, amoxicillin with clavulanic acid, azithromycin, and phenoxymethylpenicillin were mostly used to treat self-diagnosed RTIs. And here I quote some participants. One said, "When I have flu, I have headache, sore throat, and I cannot use my nose to breathe. It blocks. So I use boiled eucalyptus plants to steam and 2 color tablets, amoxicillin," he was referring to amoxicillin, "to get better." Another participant said, "I use cotrimoxazole for cough and azithromycin for sore throat and blocked nose. I should take care of myself more than anyone." In this particular case, pharmacists confirmed that pharmacy clients were having this self-medication with antibiotics behavior, but at the same time, pharmacists complained about this behavior. So one pharmacist said, "Clients' behavior is something else. I don't know how to classify. People think they don't need doctors. The person has flu, fever, cough, or pain, comes to the pharmacy instead of going to the doctor. There is a concerning behavior of self-medication," the pharmacist said. So in this study, we found that in this, using this quotation and this data, we found that self-medication with antibiotic is part of beliefs of medicines and is perceived as individual responsibility. So a group of pharmacy clients said, "With sore throat and flu, you don't eat well, you cough, and it's embarrassing, keep cleaning your blocked nose." Amox and Cotricia. Amox refers to amoxicillin. Cotricia refers to cotrimoxazole, is the commercial name. So Amox and Cotricia does it in 2 or 3 days. Remember that we said that some viral respiratory tract infections disappear in 7 to 10 days without antibiotic treatment. In this case, out prescriptions to treat in 2 to 3 days as their expectations. So participants also easily made associations between the viral RTIs and the weather. And another group said, during this changing season, they were referring to the transition from summer to winter, we are more likely to get flu and cold. Adults suffer and kids suffer too. You cough, your airways keep blocked, and your nose is wet. Then at the healthcare center, you queue all day. Participants also perceived the pharmacy as the first option when they feel ill, regarding the fact that some public healthcare centers were full and there were long queues to access the physician or a healthcare professional. So one participant said, "At the pharmacy, you get help in very few time. You get the drugs for cough, fever, nasal congestion, pain, you see?" This also shows that participants made associations between viral RTIs and the importance of being healthy while believing antibiotics treat all diseases. A group of participants said, "You don't go to the hospital to cure with diseases like flu, nasal congestions, and colds. Flu affects your ability to work and concentrate. You keep coughing. I immediately get asthma. That's why I need Phenox and Cotricia." They mean phenoxymethylpenicillin and cotrimoxazole. So, and these narratives are concordant to the literature evidencing that viral RTIs are among the most common health problems leading to the practice of self-medication. Literature also indicates that the misuse of antibiotics for viral RTIs contributes to the increase of bacterial resistance to antibiotics. So in terms of final remarks, we can say that while to breathe is universally perceived as a vital sign, viral RTIs are socially constructed and perceived as affecting the ability to breathe properly. antibiotics, there's prescription-only medicine, especially in Mozambique, in many other countries, are commonly used for self-medication practice in a day-to-day need to self-treat viral RTIs and other diseases. And studies from different parts of the world have shown how self-medication is the most common medical action. I'm citing Van der Gest et al. So there's a constant effort to maintain the health, breathe, and continuing with daily activities. The viral RTI symptoms referred by the participants do not necessarily require antibiotic treatment. However, they were effortless, requested, and dispensed with no reference to the physician's prescription. So this takes us to the fact that individuals take actions and an active role in their health disease process. They indulge in practice of self-medication and use antibiotics or any other medical resources available. By making use of their health rationales and their social perceptions of health disease process, individuals immerse themselves in the process of self-diagnosing and self-treatment. And they express the need to breathe, to keep going. This was not perceived by them as misuse, rather as utilization of medicines, in this case antibiotics, as very powerful medical resources. As stated by Webster et al., for many people, drugs are the most important and physically tangible form that medicine as practice takes. In this sense, antibiotics act as not merely a chemical, but a social encapsulation combining definitions of heal, health, the body, and treatment, according to Webster. So people socially construct the meaning of medicines and link it to their own state of health to cope with it within the context of their daily life. People also create knowledge bases for their treatment regime through what we may call lay pharmacology. So in this case, assessment and comprehension of the social constructions, the rationales, and health-seeking behavior regarding the practice of self-medication for viral respiratory tract infections are needed, but also mapping knowledge gaps to design contextual interventions and awareness raising towards the suitable utilization of antibiotics is paramount in Mozambique, especially in Maputo City. And finally, I would like to kindly invite you to look at self-medication with antibiotics in light with the everyday and practical reasoning, according to Reid. So I found interesting how illness is seen as individual experience and medicines, in this case antibiotics, as medical resource and healthcare practice of daily life, day-to-day life. So this practice of self-medication with antibiotics for viral respiratory tract infections emphasizes the self-reliance and individual responsibility for one's own health, while contrasting with global public health efforts to control antibiotic use. This is the end of my presentation, and thank you for your attention.
Wonderful. Thank you very much, Neusa. Thank you. And it went well connectivity-wise as well.
Thank you very much.
Yes. Right. So I think, Neusa, if you can, maybe stop the screen share, and we'll have an opportunity now for questions and comments on both of the talks that we heard. I just want to open the chat as well, so we can monitor that. Carla is also saying thank you very much for the presentation. Yeah, these two contrasting, you know, Steve talking about this this vicious disease that COVID causes, and we wish we had a drug or an antiviral drug, and we're so searching for a vaccine. And then Neusa talking about the misuse of the few effective drugs that we do have, and certainly we are all very dependent on medicine, and many of us just think of healthcare in terms of access to medicine. So really lovely, and all of you speaking about life and breath as so crucial to life, and how it just, you know, even someone with a milder respiratory tract infection saying they can't breathe properly through a blocked nose, they can't work, they can't concentrate, and they want effective treatment very soon. Right, so let's open the floor for questions. I'm struggling with the unmute, sorry. Catherine, yes, you have a question.
Yes, I've got a question that let me see if I can make my video go. Hello, everyone. I've got two questions. The first one is to Neusa about the comfort levels inside of chemist shops. You've spoken about time a lot and antibiotic purchase and some really interesting data. I wondered if you could tell us a little bit more what the pharmacy or chemist shops feel like, whether they are slightly air conditioned, whether they have very clean floors, whether they have other aesthetic elements that make them feel like places that people who are struggling to control infections or what they believe are bacterial infections, they feel drawn to or attracted to, possibly the mother of a child or somebody's partner. So something more about the environment and the sense of being of people inside of those spaces, including ones that might be quite rudimentary or simple, or perhaps ones in Maputo that might, you know, sort of have a kind of international metropolitan feel to them. And then I also wanted to ask Steve if he could talk, and I'm sure these are thoughts that have been going around in his head in relation to that beautiful presentation. What was the soundscape of the Hope Center like in the periods before, leading up to, and then after the mass sort of singing that Sunday, and then in the build up to and then after your young colleague was playing his guitar? In other words, if we were to have a tape recorder in that center for the whole time it was open, what would be the ordinary sound? What was the soundtrack of it like most of the time? What was the sound of beeping machines or breathing machines or people talking loud or soft, because there were no carpets and not linoleum floors? Was there a lot of foot traffic? So how did the choir soundscape and that music, and then the guitar being played, how did that come into or out of other soundscapes? And my last question is, as people held cell phones up to people's ears to try and talk to family members in these very poignant and difficult moments, how amplified or not was that sound, given that you had to go through PPE equipment, possibly the person who was suffering had to have some kind of a mask over their head during it. I just wanted to get more of a sense of whether this was like a drop in the ocean, that huge choir singing and then the guitar, an ocean of other sounds, and how to sort of denaturalize those sounds and bring them forward. Imagine if we had like a concerto in several parts of a day, in each day in that hospital's existence, what would that broader soundscape be like? I'll close my questions there. Thank you very much, Berna.
Sorry, something happened there. Right, Neusa, do you maybe want to go first in responding to your question?
I'm sorry, Berna. I think I lost the first part of the question from Catherine. Please, can you come again? I'm sorry. My connectivity is not that well today.
Oh, sure. I just wondered if you could tell us a bit more about what the chemists and pharmacy shops feel like for people who go there. You told us a lot about the time and the convenience and those wonderful quotes that you've got from interviews about the simultaneity. You can get a number of different medications at the same time and in a sort of rapid way. But I wondered if you could tell us a little bit more about other appealing features to people going in to purchase those medications. Something about how they look, something about how they smell and feel, etc., etc.
Okay, thank you very much, Catherine. Well, the study was regarding the exploration of the practice of self-medication with antibiotics. So within this study, we found many other information regarding other fields. Yeah? So I used extracts of this study to link to this respiratory tract infections, the viral ones, and to this symposium. So what I remember that most of the participants were complaining, and I have it in one of my published articles, is that first, healthcare system conditions were the problem. So they had problems to access, to easily access the physician or healthcare professional. They had problems to access the medicines at the healthcare centers. And most of the times, after going to the physician and being prescribed antibiotics, most of the times in the local or public pharmacy, public health pharmacy, there was shortage of antibiotics or that certain antibiotics. So most patients were referred to the pharmacy. So what we could say is that patients, they use this health information for the next event, next sickness event. For that moment, they go to the pharmacy because to the private pharmacy because the private one has shortage of that, the public one has shortage of that amoxicillin, for example. And then they go to the private pharmacy where they have to pay more because in Mozambique, the public healthcare service is subsidized by the government. So instead of paying R5 to get all the medicines prescribed, they had to go to the public pharmacy to spend like 100 rands. I'm talking about rands because it's the most familiar. Okay, so this was the first thing, the health system conditions, the healthcare system conditions. The second thing was the pharmacist practice or the professional practice of pharmacists. Although it's illegal to prescribe, to dispense antibiotics, it's illegal. It's by law. You can't, as a pharmacist, dispense antibiotics without a prescription, and it should be a valid prescription. But pharmacists in Mozambique and many other countries, especially low and middle-income countries, are dispensing antibiotics, large spectrum antibiotics, ample spectrum antibiotics for without prescription for patients, without asking at least what for, or without asking the history, medical history of the patients. This is the second issue that it was appealing for us, and we did investigate. So regarding the medicines and the antibiotics themselves, participants associated the shape, the color, and the efficacy, especially the efficacy of the medicines with their practice. Oh, one example is like, they know that these two-color antibiotics, they refer to amoxicillin because in Mozambique, amoxicillin comes in two colors. It's red and yellow. Okay, I think in South Africa also, it's red and yellow. So they call it two colors. They don't know even the name amoxicillin. This was informed by literature and by our readings. And they also don't know they are treating viral respiratory tract infections. They don't know these terms, these medical terms. What they know is that there is two-color tablets, and this is used to treat cough, to treat general pain, to treat fever, to treat even wounds, okay? So there is association with the medicine as an object, as a tangible object, with this illness and perceived need for self-treatment to get rid of disease symptoms. I'm not sure if I got your question, if I answered it. Please feel free to come again.
Thank you. That was very interesting. Thank you.
Thank you. Very nice context, making us experience some of that. Right, then I think we can move to Steve. Steve, if you want to respond to Catherine's questions to you.
Yeah, sure. I was intrigued by that question, Catherine, and also interested in sound myself. So because there was no ceiling and there was just this very high roof, it was very echoey, which made it wonderful for singing, but there was always this background noise, sort of punctuated by the beeping of machines and a sort of shuffling noise all the time. What I found extraordinary, though, was that, you know, COVID is primarily at the beginning a pneumonia. So you would expect, you know, a couple of hundred people in one space with pneumonia to hear a lot of coughing. Well, there was virtually no coughing. And I remember asking one of the consultants, like, what's going on here? If this is COVID pneumonia, why is no one coughing? And he said, well, it's a different mechanism. It's not producing the same degree of mucus and stuff that needs to be coughed out. So there was in fact, when someone was coughing, there was often something else going on. So that was a sign to us that we needed to look for some cardiac problem or whatever. But it was a very busy sort of space most of the time. There was always the sense of movement, and it certainly wasn't restful. It did calm down on the Sunday afternoon, so the singing was a welcome relief from the tedium of that. But yeah, interesting.
Great, thanks, Steve. I think there was the question about the cell phones and use of cell phones, and that, Catherine, maybe you can expand there, but the soundscape of the cell phone.
Yeah, no, because there was so much background noise, the conversations were pretty private, like you couldn't really hear them at any distance at all, because there was so much sort of, as it were, white noise all the time from over the top of the of the partitions. So
can I just ask one little piece, Berna, on that? You know, if you're in a convention center normally, which I kind of avoid, but I'm sure all of us have had to be in one at some point, usually for a conference. One of the things that's often so striking is the piped announcements, like in an airport or something, and often piped music, like a hotel, when you're trying to move between breakaway rooms or something. And it's actually really annoying, and it's sort of overwhelming. It's like the air conditioning. It's like a kind of white noise. Did anybody think about piping music over? And would that have been ludicrous? Because there would have been all these speakers and everything.
We certainly did think about that, but we weren't allowed by the convention center management to use their system. They would have charged us some extra thousands a day to use their PA system. So we couldn't do that. That was our first thought. And then we thought of bringing in people to play music, but that would have introduced an infection risk. So, you know, we successively tried a number of different interventions until we used the nurse, really got the nursing staff going, and some of the doctors. So it was really an inside job.
Lovely. Thank you, Steve. I love that, an inside job. And how interesting, Catherine. Thanks for making us think about that, the sounds, you know, surrounding all of these events. Right. Any other questions? We still have as Charlotte said, we don't have to use the full hour and a half, but we do have it available. So please feel free.
I have a question for Steve. In the previous panel, Anna made a very nice link between the breath of the community with the individual breath. And I couldn't help, while I was watching your video, thinking about the singing as being a manifestation or physical manifestation of the breath of the community. I know that when I listen to music with words, I tend to my breath tends to follow the same rhythm of the music. And I'm wondering if that could subconsciously have made an effect on the patients, that with the singing go past, they know the songs themselves too, that they kind of take the breathing of the song as a crutch while the song is happening. And therefore we have that, that movement from individual breath to community breath, even if at least just for a few seconds or a few minutes.
Yeah, absolutely. So, I mean, music, the major elements of music are harmony and melody and rhythm. And particularly with the sort of singing that we did, the rhythmic part, the periodicity that aligned everybody with the same often dance was really what brought us together, I think. And people would want to move their bodies in time with the rhythm, which is parallel, I suppose, to the rhythm of breathing, the periodicity of it, the in and out, the on and on, the on and on and on and on. As you saw, you know, we went down the one row and up the other and down the one row and up the other. It must have taken, you know, 15 minutes. We were still singing the same song. And that was the wonderful part of it. You know, everybody was drawn to this thing, absolutely drawn to that. I was quite worried about like too many people in too small a space, you know, physical distancing and all of that, but they were in PPE. But I think it's the rhythm that maybe, Charlotte, you're referring to, that draws people in, particularly in African dance and singing, that brings us together.
Thank you.
Lovely, thank you, Steve. There are more questions for you. I don't know if you had a chance to read that. You know, if everyone just wants to have a look at the question Alberto asked in the chat, and Catherine added to that whether or not people reference the Jerusalem song.
Yeah, we did the Jerusalem song at the end as a sort of celebration. But no, certainly people, the patients were not all by any means Zulu speaking or Xhosa speaking, and many of them didn't know the songs. But by the time we'd been through the wards, you know, 10 times, they knew those songs. And it was this thing, like I concluded that singing together kind of brought out a common humanity, I felt, between the professionals, the patients, the different levels of staff, the cleaners. The cleaners were a big part of the staff, and they were the most enthusiastic. They got down there, you know. So yeah, I think that it would have had different effects on different people, but there was certainly a sense of we're in this together.
Great, thank you, Steve. Then Catherine has written another question to Neusa. Have you had a chance to read that one?
Yes, I'm reading now. Okay. Yes, Catherine, thank you very much for the question. Yes, people, they didn't talk about the cleaning thing of the pharmacy, but the courtesy, yes, because most of the participants said, okay, when we get to the pharmacy, and we just say, okay, I have cough or I have fever since yesterday, or my son or my daughter, and the pharmacy was quick to assist them. It's different from the public health health center. So the thing of courtesy is the question of courtesy was very meaningful for the participants. But there's another aspect that it's important to reference regarding the pharmacies. is that in Mozambique, especially in Maputo City, the proliferation of pharmacy stores or private pharmacies is growing. And I can say that government is lacking to control the authorization of new pharmacies. So people are now making association with pharmacies and healthcare centers, especially the public healthcare centers. So there is the thing of courtesy, yes, but the proliferation of pharmacies is a big issue. So we have to consider that. The other aspect, and very important, is the question regarding the way people can buy antibiotics from the pharmacies. I mean, when the physician prescribed like 21 amoxicillins for like 3 or 5 days, taking one every 8 hours, and the client or the patient feels that can't afford the 21 tablets, he can go to the pharmacy and buy just the half of the prescribed antibiotics. And here we have two things. Pharmacists are indulging in unethical professional practice, but also they are not explaining to the patients, to the clients, that this is not a very good practice for their health. Here we can just bring up the question of generating profits from the pharmacies. So we are talking about private pharmacies. The public pharmacies in Mozambique, they don't allow, they don't sell, they don't dispense antibiotics without prescriptions. But there's, and we can say in Maputo City, we can say like we have almost 60 private pharmacies and against, let me say 15 public ones. And most of the public ones, they lack some medicines. They have shortage of antibiotics as the public health pharmacy health centers. So there are many issues regarding this access to the pharmacy. There is the availability, there is the accessibility of antibiotics, but also there is the need for profit from the pharmacy clients. And we can call here the supervision and the accountability mechanism from the health authorities. So it's a mixed pot with a soup, we can say. But we can also say that pharmacists are regarded as having more courtesy than the healthcare professionals, especially at the public healthcare centers. I hope I have responded to your questions. So the sense of peace and the sense of calm and control, yes, it's there. Because when you go to the hospital or the public hospital and you have to wait from 7 to 3 to be assisted by a physician, while you have this around the corner, a pharmacy, private pharmacy, where you have to pay more, but you get the attention, and the pharmacists, although unethically and illegally, are willing to assist you, you are more likely to go to the pharmacist. And what is more relevant here is that most of the participants, they made associations with past sickness events. I mean, if last week or last month I had fever and I have a cough and I had the common flu, I went to the hospital, okay? And they gave me amoxicillin or they gave me any other medication. The next event, and I had to take like all day in that hospital or healthcare center. In the next event for my husband, my kids, or any other person, I would suggest and I would share the information like, okay, you're going to take like 8 hours at the hospital. So it's better to go to the pharmacy because they will prescribe this. So pharmacists, interestingly, pharmacists, they were blaming physicians to over-prescribing and prescribing the same antibiotics for many patients and for different disease conditions. There's another issue. So this has a relevance to medical humanities in the sense that health information or medical information is being used in a daily life for lay people, okay? And most of the times for non-necessary disease, okay? Most of the time they don't need this antibiotics, but this is becoming a daily life in Maputo City among these participants, and it's really concerning.
Okay, thank you so much. Then Sumaya and Carla also wrote in the chat that they have questions. Sorry, Carla wrote first and I missed that one, and I said to Sumaya she can go. So maybe Sumaya, Carla was so gracious to say you can go first.
Thank you, and thank you, Carla, for being so gracious. Good afternoon, everybody, and thank you, Neusa, for your presentation. Steve, unfortunately, I missed your presentation, but I just have a question for you, please. I'm a physiotherapist, and I don't practice anymore, really, but there was a friend of ours who's a specialist physician, and he contracted COVID now during this period, and he was quite ill. And he asked me if when he was discharged from hospital, if I would do his rehab with him. And we had a very, so basically his treatment happened over Zoom. So he would have his video on and I would have my video on. And I'm thinking about the stories and the narrative you were relating about, the singing in the wards. And I'm reflecting on when I was going through the sessions with him, how important the control of breath was. And so when did you find that through the singing, you may have mentioned this before, so I apologize if it's something you mentioned before, but did you find that through the singing, you were also giving patients the opportunity to, as a form of rehabilitation, because they needed to control the breathing as they were singing? And do you think that offered them hope in terms of the recovery and how they were able to control their breath? And also that it was a collective kind of participatory activity. Do you think that people gain strength from doing this collectively? Thank you.
Yeah, Sumaya, the staff did most of the singing. Some of the patients joined in, those who could, and maybe it did them some good. And there was a team of physiotherapists who focused on breathing exercises. So the important thing was to reinflate the lungs, the areas that had collapsed from the pneumonia. Yeah. But there's some papers, a lot of papers written about the effect of choirs amongst patients with chronic obstructive airways disease, where the problem is not breathing in, the problem is getting the breath out.
Yeah.
And what they have described is that singing helps with the expiration, because it's measured and it's prolonged by singing a long phrase or whatever, and that the collective aspect of it is hugely beneficial. So you don't feel like you're alone, you feel like you're with others who are facing a similar sort of challenges. So there is another presentation as part of the symposium. I think it's a movie, Carla, that is based, that was made in London, that shows the effect of singing, the singing hospital. Okay. Another example of that, where the emphasis is on the patients. This was completely spontaneous amongst the staff, I suppose, mostly. Yeah.
Thank you. Thank you, Steve.
Thank you, Sumaya. All right, then, Catherine, now it's your turn. Carla, sorry.
Thank you. Thank you very much. I have a kind of two-part question and I suppose a comment. The first thing that's been interesting about this panel and this earlier panel this morning is the notion of singing and dancing and how they move. And to me, it kind of links in some ways to the point you made. Tiana in the workshop this morning was talking about how in therapeutic spaces, especially linked to respiratory illnesses, telling people to do things like go to gym, people only do it as much as they have to until they feel well enough because it's not necessarily enjoyable, whereas something like dancing, which requires movement and is linked to memory and sense of community or belonging or youth or, you know, particular affiliations with songs, people commit to for longer periods of time because there's an element of joy in it. And that kind of in some way seems to me to link to, Steve, a lot of what you're talking about that there's a sense of connection and belonging and joy in the singing and in listening to the singing and being part of it that speaks to, as you say, something that's not about the crisis of the health at the moment, but about a much bigger sense of the self. So a sense of the person not as unhealthy, but as a person that is ill now, but has this whole other component part to themselves. So I just thought those were kind of quite interesting. My other interesting thing, the thought that came to me, Neusa, in terms of your presentation is that there's these kind of interesting overlaps of authority in what you're talking about. So there's the kind of formal legal authority about what can and can't be dispensed in a pharmacy and, you know, what's legal or illegal. Then there's the sense of patients having a particular sense of their own authority of what they want for their healthcare, and so seeking that. And then, you know, the tensions of the knowledge between doctors as prescribers of medication and pharmacists as specialists in medication, and how they, you know, that kind of conversation is often quite a complex one around who has insights or ideas around functionings and practicalities and where that particular power dynamic lies. And I'm thinking about how all of that and the other underlying thread that I'm hearing in your presentation is around this idea of the kind of connections between convenience and capitalism in some ways, and that it's inconvenient to stand in a queue, it's inconvenient to take a day off work when you think that all that's going to happen is that you're going to get the same thing you got last time that it took you a day's worth of your time to get to. And a pharmacy allows this much easier, much quicker, much more convenient space, but at the same time this rise of the private pharmacies and the sort of the further eroding of public health because it's more convenient or their stock or there's, and how those tensions are so manifested kind of globally in terms of the public-private healthcare tensions. So yeah, I just, sorry, there was just a kind of circuitous set of connections that I thought were very interesting in the points of how the tension, and also, I mean, I think you said one of the participants was talking about not wanting to miss work by spending a day. So also the pressure of being able to be healthy, that you must be able to perform, you must be able to, you have to be functioning, that to be non-functioning is somehow to be less than. And I just think those are very interesting interactions. So I just wondered, so to my questions now, what were did any of the doctors or any of the pharmacists speak about doctors and pharmacists and what kind of conversations they have with each other or the professional boards have with each other? Because it sounds like there also needs to be communication happening in that space. And Steve, and going back to the ideas of joy and your very first story about the older patient who then on the cell phone sat rate went up, I'm wondering if there's some sort of connections with ideas like laughter yoga, which require you to like fake laugh essentially, both as a mechanism of increasing breath, but also have to do with the sense of feeling hopeful or joyful, that the sound of somebody that you love on the other end of the phone would make you go, would kind of, it's like when you know at an airport, when you wait, or a port, or when you're waiting for a family member to come home, you kind of hold your breath until they come through the door. And then when you see that, there's that moment of release. And I wonder if there isn't something of that, something about recognition and delight and joy, that when you hear a familiar voice or a voice you love, that, I don't know, opens us up a bit. It's just a hypothetical space. Thank you.
Absolutely.
Okay, thank you, Carl. I think Berna, can I?
Yes, yes, please.
Okay. Thank you, Carla, for your comments and for your question. Yes, this is a kind of a huge concerning in Mozambique. This tension between the doctors prescribing and the pharmacists dispensing. And also there's another side of this story, which is the proliferation or the rise of pharmacies, the private ones, and the profit thing, the need for profit from those pharmacies. So the pharmacists, as professionals, they are aware that dispensing antibiotics without prescription or valid prescription is illegal, but they are kind of in between the wall and the wall. I like to say the wall and the wall. It's not the wall and the swords. It's the wall and the wall, because it's, in one hand, they know the healthcare system conditions, the difficulties people have to access a physician, to access consultation, to access medication at the healthcare centers. They also know that they are aware that there is this lack of accountability mechanisms. There is this need for profits from the pharmacy owners. So they, at the same time, they position themselves as not to blame, as like they're in the middle of a big problem. The owner wants profits. The clients, they want courtesy, they want the medicines, and we are here to sell the medicines. I may say sell, but this should be dispensing, okay? So they're here to sell or dispensing the medicines. But there is also this thing that the health authorities and the government, they're not providing, or they are not able to provide or assist, especially low and middle class people with health service, healthcare service, good healthcare service, and they cannot afford to go to the private healthcare service or systems. So the pharmacists, they saw themselves, and I have this in one of my articles. I can then afterwards share with you. The pharmacists, they see themselves as being in the middle of this world and world, but they recognize that they admit that they are indulging in unprofessional practice. And the other thing that moves or incentivizes the pharmacists is that there is no consequences, okay? Although there is supervision for pharmacies, private pharmacies and public pharmacies, there is supervision, there is, I can say, control. Any pharmacist was I can say, was sued or was fined because they dispensed non-prescribed antibiotics. So the pharmacist said, we need a pharmacy health professional association, okay, or association of pharmacists. We need that to organize the pharmacists, to make sure that pharmacists are acting in a good way, so that they don't dispense the antibiotics without prescription, because they feel themselves as being pressured by the pharmacy owners because of the profits. Okay, this is a point that we found regarding the pharmacists and the profession. Regarding the patients, is what I've said before, is that they want the service to be provided as fast as they can, and in a cheaper way, in the way that it's adjustable to their pocket, adjustable to their money. If you can buy, instead of 10 to 21 tablets, you can buy 10. For them, it's fine. They want to get rid of disease. There's this self-treat. They need to breathe. They need to be healthy. They need to keep going with their activities. And this is what motivates the most the participants. Of course, there is the health-seeking behavior behind this that we need to also look at it. But there are many issues in the same pot that we sometimes, I don't know if the public health authorities, they know where to start. But I think that starting with the health-seeking behavior and working with people and working with this socially perceived and socially constructed perception of medicines and antibiotics will be more helpful for the health public health authorities.
Thank you, Neusa. This is so exciting. We've actually gone 2 minutes over time. And Carla, this is, if we had a real, a live conference, this is the conversations that we'll continue having over tea. But let's just give Steve a chance to respond, and then I think we'll need to end.
Just to Carla's point about joy, I often feel when we sing, we have to become children again. We have to be in that vulnerable space of just not worrying, and something like that happens when you sing. So let me leave it there. You muted.
I know you're mute.
Sorry, there I'm defeating the whole point I wanted to make about music and sound. You spoke, Steve, about how you were able to cross barriers, through barriers of PPE, language, all of these things, industrial type environment. Yeah, sound and singing and music certainly intrigues us all. So lovely. Thank you for sharing your very valuable experiences and your hard work and your insights, and for the audience for listening so attentively and participating in the comments, and for the lovely discussions we've had. And just thanks again to Carla and Olwazi and Charlotte for putting all of this together and giving us the opportunity. It's really been a pleasure.
And just before we end, can I just let everyone know that on Friday we have our first keynote, and it's Dr. Ella Manga, who is a medical doctor and author of 3 books on breathing and breath. And she's one of the leading voices on mind and body medicine. So please join us at 3 o'clock until 4 o'clock on Friday, the 30th of October. And that also to say that next week's panel on Wednesday is going to be looking at issues around the environment, climate change, and breathing. So please join us for that, starting at 1 o'clock. Thank you.
Okay, fantastic. Yeah, let's get that in our diaries. Thank you, Norwadi. And thanks. Then I think we can say goodbye for now. Bye, everyone, and thank you.
Thanks, Benna.
Bye-bye. Thank you very much to invite me, and thank you very much, everybody. Bye.